knows, this is a joint session. This is cardio sessions. From now, it's a joint sessions with the 12 de Octubre Hospital in Madrid. For us, it's an honor and a privilege that getting in the same sessions. That is the cardio choose and cardio 12 de Octubre. For us, is very important getting all the cardiology department of the 12 de Octubre in Madrid in these sessions, and after now we will organize jointly the session. So in the beginning, Fernando Rivas, that is the head of the cardiology department in the 12 de Octubre Hospital in Madrid, will give the welcome to John, and also the welcome to this new era of these sessions. So Fernando, thanks for being here in these first joint sessions with your department and your hospital. We are here in our meeting room on the School of Medicine. Please, if you wish to say something.
Sure. Yeah. Thank you very much. Thank you very much for being here. First of all, I want to say that I'm really excited about this new path we are going to take, because I guess this is the beginning of a very, very fruitful cooperation. Thank you very much, Mr. Ramon, for taking us in this direction. And I'm sure that this will be not only joint sessions, but probably we can do much more regarding technology, scientific production, and whatnot, teaching and education. So thank you very much, and I'm just waiting for Professor McMurray. I'm longing for hearing from him.
Thank you, Fernando. We are looking forward to a more close relationship between our two departments, and for us, as I said, it's really an honor and a privilege working together, not only in this continuous medical education activity, but also in our fellowship programs, and as you said, in other activities related with our cardiology, also research grants and programs. So we are starting now with the J V McMurray session. I proceed to present J V McMurray. He been here yesterday night, giving another lecture, another activity. So we start. I close this call, and you continue attending the session by the web. So thank you and have a nice day. So this is some problems we have because we have arranged a direct link connection, but it doesn't work at the present time. Only works the 12 de Octubre Hospital. Another cardiologist in Spain attending this session, this first session, these joint sessions with the 12 de Octubre. And for us, again, it's a privilege to having J V McMurray here for giving a second lecture. This is the lecture in these cardio choose sessions from in our department and the hospital. And now John discussed the role of SGLT2 inhibitors in cardiovascular disease. So thanks, John, for.
So thank you very much. I'm sure you won't think it's a privilege having to listen to me 2 days in a row, and my stress levels have just been doubled by finding out that I'm speaking to Madrid as well as here in Santiago. So today I want to talk about this new class of drugs called SGLT2 inhibitors and their role in the treatment of patients with heart failure. These are my disclosures. Now, this is an expression that's very common in the United Kingdom. So people often say an apple a day keeps the doctor away, as really something about the importance of eating fresh fruit and healthy living. But in fact, there's more to it than you might think, because in the late 1880s, this German and French scientists, physicians, discovered that there was a chemical in the bark of apple trees that did something interesting. And first it was shown that this chemical called fluorescein, isolated from the bark of apple trees, caused glycosuria in dogs. And then the same was shown in human beings. But this was never taken any further. It was thought to be an interesting finding. It was even suggested that this chemical might be a way to treat patients with type 2 diabetes, but it never went any further because this chemical called fluorescein caused gastrointestinal disturbance. And it was forgotten about for a long time. But in fact, fluorescein is a sodium glucose cotransporter inhibitor, and it's a non-selective sodium glucose cotransporter inhibitor. It's a very powerful collector of SGLT2, which is found in the gastrointestinal tract, which is why this chemical caused gastrointestinal disturbance. And as you can see here, it wasn't until 2008 that the first selective SGLT2 inhibitor was discovered, one that acted only in the kidney and didn't cause gastrointestinal disturbance. And the reason I put this timeline up is that I think it illustrates how modern medicine moves so quickly. So the first selective SGLT2 inhibitor was given to a human being in 2009. And by 2010, the first large cardiovascular outcome trial had started. And by 2015, the first large trial with one of these drugs had already completed. And that was a trial called EMPA-REG Outcome. It was a trial in patients with type 2 diabetes. One of the many interesting things in that trial was that there was a reduction in admissions to hospital in patients with type 2 diabetes, reduction in admissions to hospital for heart failure. And that led us to then plan a specific trial in patients with heart failure. And the very first trial with these drugs in heart failure was published in 2019, which was only 10 years after the first time a person had ever taken one of these molecules. And a year later, the second large heart failure trial, which was called the Emperor Reduced trial, was published. So within 2 years, suddenly we had evidence about the effect of these drugs in patients with heart failure and reduced ejection fraction. So that's what I'm going to focus on for the remainder of today's presentation. But I do want to emphasize, if you were here last night, you will have heard me say that these drugs are as big a breakthrough in the management of chronic kidney disease as they are in the management of heart failure. The first ever drugs shown to reduce mortality in patients with chronic kidney disease. So for this morning's presentation, I'm going to split it into two parts. I'm going to do what for most of you will be revision, so very quick review of those key heart failure trials. And then I'm going to talk about some new data. So let's do the revision very quickly. So I mentioned these two trials, the two trials in patients with heart failure and reduced ejection fraction. And remember, these were trials not just in patients with type 2 diabetes, but even in heart failure patients without type 2 diabetes. And thinking back to when we were planning DAPA-HF, that was a huge discussion that went on for many months about whether we should just do the trial in patients with diabetes or whether we should include patients without diabetes. And I'm glad that we did choose to include any type of patient with heart failure and reduced ejection fraction, because as you can see from these two figures, that the effect of an SGLT2 inhibitor was striking and consistent. So you can see that the hazard ratio in each trial was identical for the same endpoint, 25% relative risk reduction. These are the same y-axis scales, 0 to 40%. Two different drugs in the same class, identical treatment effect, very powerful evidence. And even more importantly, this benefit of SGLT2 inhibitors in heart failure with reduced ejection fraction was additive, was incremental. It was additional to the benefits of all the other treatments that we have. So this is a meta-analysis of those two trials. And I've shown you this specific subgroup, which is people receiving sacubitril valsartan or not receiving sacubitril valsartan. So here are the patients receiving an epilysin inhibitor. Now, I'll just point out that more than 90% of these patients were getting a beta blocker as well, and about 75% of them were getting a mineralocorticoid receptor antagonist. So they were incredibly well treated. And you can see that clearly there was a benefit from an SGLT2 inhibitor added on top of all of those other treatments. So this was additional benefit. And I'm sure you know the rest of the story very well. If you look at the two components of that composite endpoint, heart failure hospitalization, cardiovascular death by themselves were reduced. In diabetes, we even saw a reduction in overall mortality. Patients feel better. Their symptoms are less likely to deteriorate. I'll come back to that later. And of course, these drugs also protect the kidneys in patients with heart failure as well as in patients with diabetes. And again, I'll come back to that a bit later on. So for HFrEF, in those 2021 guidelines that we published, already SGLT2 inhibitors were in this table of very special drugs. These are all the treatments that have got a class 1 recommendation. Beta blockers, MRAs, sacubitril valsartan all reduce mortality. So do SGLT2 inhibitors. So these are the strongly recommended drugs, and we've become very fond of showing slides like this, pictures like this, talking about the pillars of treatment, the foundational therapies. Most people describe this as 4 pillars. I think it's actually 5, because there are in fact 5 distinct pharmacological therapies. Just sacubitril valsartan happens to be 2 different pharmacological agents in a single pill. But anyway, for our patients, it's 4 tablets. So that's heart failure with reduced ejection fraction. Now, I talked last night about heart failure with preserved ejection fraction and mildly reduced ejection fraction. 2 more trials, 2 sister trials, much bigger trials. So you can see here now, instead of 4,000 to 5,000 patients, we're now talking about 6,000 patients. The reason for that is that patients with heart failure and a higher ejection fraction have a lower event rate, and you need more patients. So 2 trials with the same 2 SGLT2 inhibitors, published a bit later, because we did these trials second after HFrEF, but really the same results. And I showed you this last night. Now, you can see here that the y-axis is no longer 0 to 40%, it's 0 to 25%, so lower event rates, and a slightly smaller treatment effect, 20% roughly relative risk reduction as opposed to 25%. But again, extremely consistent benefits in these patients with heart failure and an ejection fraction above 40%. And again, yesterday, if you were here, I mentioned the fact that we were able to obviously combine these data sets because we had a lot of patients covering the whole range of ejection fraction. And we published an analysis looking at the effect of treatment across the ejection fraction range. And you can see here, this is the continuous hazard ratio, the 95% confidence intervals, the range of ejection fraction, completely consistent. The hazard ratio is consistently below 1 across the whole spectrum of ejection fraction. No evidence that ejection fraction modified the effect of treatment. The 95% confidence intervals are a bit wider at either end because, of course, we didn't have many people with an extremely low ejection fraction. We didn't have many people with a very high ejection fraction. And the Emperor investigators, including your boss here, have published very similar findings from their trials. And again, as I said last night, this really separates SGLT2 inhibitors from other treatments that we have. None of our, I suppose, what you might now call traditional treatments that act through neurohumoral systems, none of these show that consistent benefit. All the other treatments we have show an attenuation, a reduction in benefit in people with a more normal ejection fraction. So really a huge breakthrough for patients with heart failure and preserved ejection fraction, particularly after a very long time, because we really had no evidence of benefit. So about 3 weeks ago, we published an update on the 2021 European Society of Cardiology guidelines, and you can see this very strong recommendation for SGLT2 inhibitors in these two other groups of patients. So now in heart failure with reduced ejection fraction, mildly reduced ejection fraction, preserved ejection fraction, these drugs have a class 1 level A recommendation. So if you've been doing heart failure research for a long time, this is an incredible thing for two reasons. One is that it took most drugs a very long time to get such a strong recommendation and guidelines. This has all happened very rapidly, and it's taken more than 20 years for us to actually find a treatment that clearly works, where we have robust evidence for patients with heart failure and preserved ejection fraction. So I really do think SGLT2 inhibitors for us in cardiology and in heart failure in particular represent a completely new era of pharmacology. Now, one of the problems is we don't really understand how these drugs work, but we certainly know that they do work. And again, I haven't got time today to go through in detail all the other evidence that we've collected, but these drugs have many, many different actions. And for example, they reduce the risk of developing new onset diabetes. Very important. They correct anemia. They reduce uric acid levels. In fact, they even reduce the risk of patients developing gout and needing uric acid lowering drugs. I mentioned their protective effect on the kidneys. And however these drugs are working, they seem to have these organ protective effects. They're doing good things to the heart, they're doing good things to the kidneys, doing good things to the pancreas, and maybe even to the liver. And there's a lot of research going on to see whether or not these drugs also protect the liver. And I think they also protect the bone marrow. They certainly improve hematopoiesis and erythropoiesis. So that was the summary of the evidence, and I think you probably knew most of that. So what I want to do now is to go through some newer data, but I want to do it in the form of answering some questions, because in fact, sometimes when you do clinical trials like I do a lot of, some of the papers you write are written because at meetings like this, people ask you questions, and you go back and you look at the data and you analyze it and you try and answer the questions that you're asked. So this is a series of questions which sort of are questions that we've been asked quite a lot in the past couple of years. So let's do one of the easy ones. How quickly do these drugs work? And of course, the reason people are asking that question is that these Kaplan-Meier curves seem to separate very quickly. And in this trial, Deliver, we pre-specified that we would do an analysis to statistically test when those curves become different. So this is, again, a continuous hazard ratio. This is the first 30 days expanded, blown up. This is a hazard ratio of 1, the dotted black line. And you can see here that the upper 95% confidence interval falls below 0. In other words, the hazard ratio is statistically significant consistently after day 13. So within just 13 days, less than 2 weeks of starting treatment, you can show a statistically significant benefit. And that's also been shown for empagliflozin in the EMPEROR trials. So that has, I think, stimulated a huge amount of discussion because it's really challenged us to think about how quickly we treat our patients and do we do it quickly enough? Because if something works that quickly, that really means there's an obligation for us to try and ensure our patients receive this treatment. And for heart failure with reduced ejection fraction, this is a life-saving treatment. And you may have noticed that the new guidelines have also changed the way they describe how we should use all of our treatments in heart failure with reduced ejection fraction. And they now emphasize very much the importance of doing it quickly, the importance of speed, getting these life-saving treatments started early. And we've done various analyses, and if you analyze all the clinical trial data, then in fact the most effective sequence in terms of reducing heart failure hospitalization and cardiovascular death is to start with these 2 treatments, and then you can choose what order you add the remaining treatments in. And you'll note that I put or suggested you're starting 2 treatments together. You can do that. The American guidelines are very good about how they describe this. They even advocate sometimes using more than 2 treatments together. I personally don't do that very often, but I do quite routinely today in 2023 start an SGLT2 inhibitor and a mineralocorticoid receptor antagonist together in many patients. You can do it safely. Neither of these drugs lower blood pressure very much. I'll come back to kidney function later. There's no major concern. And in fact, the 2 treatments together reduce the risk of patients developing hyperkalemia, because SGLT2 inhibitors reduce the risk of a high blood potassium in patients getting a mineralocorticoid receptor antagonist. And I think if you can do it, and it sounds like you can here because you've got such a well-organized service for your patients, I think for an outpatient, for an ambulatory patient, a goal of getting all 4 treatments started in 4 weeks is reasonable. We'll come back to patients in hospital. Now, the other side of that coin is, of that question, is it ever too late to start patients? And this is, I think, an extremely important question, because lots of people say, my patients had heart failure for a while, their symptoms are mild, they seem to be stable, but that's wrong. No patient with heart failure is ever really stable. And often doctors will say, well, I don't want to start another treatment. The patient doesn't want to take another treatment. They're on too many drugs. It's too disruptive. I have to check electrolytes. They seem to be doing all right. Let's leave things as they are. But that's the wrong way to think about this. And for both DAPHF and DELIVER. This is just DELIVER. We've done analyses looking at this. So here at the bottom of the slide, you see the patients divided into different groups according to how long they've had heart failure. So some patients were enrolled in the trial soon after the first diagnosis of heart failure. Some patients had heart failure for a long time. They mainly had mild symptoms, but you can see here, this is the point estimate for the hazard ratio, 95% confidence intervals for the primary endpoint. You can see here that all of these groups of patients benefited. But these patients, these people with the long-standing heart failure, actually had the highest event rate. So even though we think because they've been alive for some time, they seem to have mild symptoms, they actually do badly. And if you follow them up for 2 or 3 years, these people have the highest event rate. But you can see here that they get at least as much benefit as people with newly diagnosed heart failure. So if you see a heart failure patient who has been in your clinic for 2, 3, 4 years, they are still going to benefit from adding an SGLT2 inhibitor. Another question that we are asked all the time is, can you start these treatments in hospital? And the answer is definitely yes. One of the reasons this question has come up so much is that our endocrinology, diabetology colleagues initially were concerned about the safety of starting SGLT2 inhibitors in hospital. They were worried about things like the risk of ketoacidosis, but we have 2 trials that have looked at using SGLT2 inhibitors in patients recently hospitalized. The biggest of these was the soloist worsening heart failure trial. So this was patients with heart failure across the whole ejection fraction spectrum. It was the only one of the 5 big trials that required patients to have type 2 diabetes. So this was only in patients with type 2 diabetes, but they're the ones who would be most at risk of things like ketoacidosis. So the drug used there was a SGLT1/2 inhibitor, but it was predominantly an SGLT2 inhibitor. About half of the patients were started on treatment while they were in hospital, and about half were started within 3 days of discharge. But just a few weeks ago, this subgroup that we're talking about just at the moment was published. So these are the people who were started on treatment in hospital, and you can see here that they clearly benefited a lot, and there was no significant risk of ketoacidosis or any other adverse effect. So the guidelines are very clear. In 2023, do start these drugs in hospital and really start them as soon as possible. And we published some recent data showing that they facilitate the effect of diuretics. They augment decongestion. So with soloist worsening heart failure, we really have 5 large trials covering the whole range of ejection fraction, covering people who are outpatients, people who are inpatients, and as you can see here, the treatment effect is really consistent. And again, if you know your history of heart failure trials, we've not seen this before. We've seen strongly consistent results with beta blockers in patients with heart failure and reduced ejection fraction, but we've never seen any treatment show such a consistent benefit across the whole spectrum of ejection fraction. So again, people ask you questions, people want to know before they prescribe drugs, do they really work? Do they do all the things, everything that you would want a drug for heart failure to do? And let's just go through that, because I think what you would like if you had a new drug for heart failure, if you could ask somebody for all of these things, you would want the drug to improve survival, you'd want it to reduce hospital admission, you wanted to make people feel better, or at least try and stop their symptoms getting worse over time. So let's look at mortality. So in that meta-analysis that I just showed you, of course, we have looked, this is cardiovascular death, and you can see, again, overall, a consistent treatment effect. The statistical test to look for here is the test for heterogeneity. So don't focus on whether an upper 95% confidence interval crosses unity here. This is a test that is really asking, is the benefit of an SGLT2 inhibitor different across this spectrum of trials? And the answer is that there's no heterogeneity. The treatment effect, which is really the point estimates here, really line up very well. And overall, there is a significant reduction in cardiovascular mortality. Do these treatments reduce heart failure hospitalization? Well, I want to show you something that may be new to you, might not be new to you. So when you see figures like this, which you've seen a lot of in this presentation, this is the standard way of us showing clinical trial results. And this is what's called a time to first event analysis. So the only event that counts in this analysis is the first thing that happens to the patient during the 2 to 3 years typically follow-up. So if you think of a patient of yours with heart failure, they might be admitted to hospital with worsening heart failure, but over the next 2 years, they might deteriorate, they might have more hospital admissions, and then they might die. That might be the typical story for a lot of patients with heart failure. But in the clinical trial results that you look at, like that last figure that everybody shows you at meetings, the only event in this patient's experience that counts is this first event. And that's important. And you can see here that these are the first events. In the DELIVER trial, you can see that there is clearly a reduction in first events, hospitalizations, and death. But I think what's really interesting is to look at all the other events that happen after the first event. And there are now new statistical methods that allow you to analyze total events. You can see that there are many more second, third, fourth events, many more hospital admissions, some deaths after the first non-fatal heart failure hospitalization. And you can see that the effect of treatment on the total number of events during the whole period of follow-up is really very substantial. And as I say, with these newer statistical approaches, you can plot the effect on total events, and you can see that there is this sort of persisting or even increasing benefit of SGLT2 inhibition in the longer term. So these drugs don't just reduce first events, they reduce second, third events. The benefit of these drugs does not wear off. Patients don't become tolerant to them. They continue to be effective. So even if a patient does have a heart failure hospitalization, it is important to continue treatment because they will continue to be beneficial. And again, just in the past 3 weeks, this really interesting analysis was done from the Emperor trials, because I think this might be the first time ever there were measurements made in patients at the end of the trial after treatment had been withdrawn. So people were randomized to placebo or empagliflozin, followed up for 3 years, and then their treatment was withdrawn, but patients came back for further tests. And you may have been part of this trial here in this center. And what you can see here, so I've just picked two things. I picked uric acid and hemoglobin because I mentioned these drugs reduce uric acid. You can see that very dramatically here. They increase hemoglobin. You can see that here. And you can see what happens at the end of the study after randomized treatment is withdrawn. in the empagliflozin group, serum uric acid goes straight back up after withdrawal of empagliflozin, and here's hemoglobin after withdrawal of empagliflozin. Hemoglobin falls again. So biochemical or laboratory evidence, hematological evidence of the persisting effect of these drugs in the long term. And then I'll show you one other thing about heart failure hospitalization, because heart failure hospitalizations come in different types. And some hospitalizations are simple, straightforward. Patient just gets intravenous diuretic, goes home. Some patients need inotropic support. Some need to go to the intensive care unit. Some might even need mechanical circulatory support, renal replacement therapy, ventilatory support. So here you can see the proportions of patients who had an uncomplicated hospital admission or a more complicated hospital admission in the DAPA-HF and DELIVER trials, and actually in patients with HFrEF in our trial, just over 40% of patients had a complex hospital admission, or in most cases that was simply requiring intensive care unit treatment or intravenous vasoactive therapies. But quite a lot of patients had a more complicated admission. But the interesting thing is, you can see here that SGLT2 inhibitor therapy reduced all types of hospital admissions. So reduced less complex hospital admissions, but also significantly reduced the risk of a patient having a more complicated hospital admission. So these drugs not only reduce hospital admissions, but they also reduce more severe hospital admissions. So again, some new evidence. And then finally, just to point out that in particularly heart failure with preserved ejection fraction, these older comorbid patients often have many reasons to be admitted to hospital: pneumonia, COPD, worsening kidney function, lots of reasons to be admitted to hospital. But you can see here that in the DELIVER trial, we showed a reduction in all hospital admissions. So it was small, but what this is telling you is that the effect on heart failure hospitalization was large enough to reduce the total number of hospital admissions from all causes. And again, from a patient point of view, that's very important. From an economic point of view, that's very important. From a hospital point of view, that's very important. And then the last goal of therapy is, of course, to try and make people feel better or stop them feeling worse. And again, we've looked at this in all of the trials. So have the Emperor investigators. I'll just show you the results from DELIVER. So this is a patient-reported outcome. This is the Kansas City Cardiomyopathy Questionnaire. This is the overall summary score. So the patient completes this. Many of you probably used this in research. And what patients are telling us is that SGLT2 inhibitors are more likely to result in an improvement in KCCQ, and that patients getting an SGLT2 inhibitor are less likely to have a deterioration in symptoms and quality of life. And a 5 or greater point change is the usual threshold we use for a clinically meaningful change. A 10-point or a 15-point improvement are really large improvements, and we have never seen this with any previous drug or device therapy. Even CRT didn't result in more patients having such large improvements in their symptoms. And this is between baseline and 8 months. You can drill down into this even further. So here are the 23 questions that your patient answers when they complete this questionnaire. The larger the bar to the right, the greater the improvement. And you can see at the top here that the biggest improvements were in things like peripheral edema, in breathlessness, causing problems, for example, sleeping. But you can see an exercise, but you can see other things. So intimate relations with loved ones, visiting family and friends out of home, big improvements. And these drugs really have a real impact on the patient's ability to lead a normal life. And then I'm going to add, I think, a new goal of therapy, because I think we can now have this as a goal of treatment in patients with heart failure, which is to try and delay or prevent worsening kidney function. And SGLT2 inhibitors do that. They cause an initial dip, decline in eGFR, but after that, the rate of decline in eGFR is significantly less than in the placebo group. So I have just two more questions I want to look at. One is to say something about subgroups, but I'm not going to say very much because it's pretty boring. Because if you look at old people, young people, men, women, patients with diabetes, patients without diabetes, all of those conventional subgroups, they all look exactly the same. There is no difference. SGLT2 inhibitors work across all of these groups of patients, and the benefit is entirely consistent. Now, I'm going to show you, though, two, I think, more interesting analyses looking at different subgroups. So a lot of doctors are always concerned about giving new drugs to older patients, frailer patients. People with heart failure and preserved ejection fraction tend to be older and frailer. So what we did was we looked at the effect in the DELIVER trial of dapagliflozin across the spectrum of frailty. And we used a frailty index, which is calculated using something called a Rockwood approach. And the more frail patients are the ones with the higher frailty index. This, again, is just like I showed you before, a continuous hazard ratio, 95% confidence intervals, very wide here because we didn't have many severely frail patients. But you can see here no suggestion at all that SGLT2 inhibitors were less effective in more frail patients. In fact, if anything, the suggestion here is that the more frail patients might even get a slightly greater treatment effect. Their hazard ratio might be a little lower in the more frail end of the spectrum. And I think even more interesting analysis, this was done by my colleagues in Boston. We do all of these things together, but this was their idea. Thought was very interesting, was to do the same sort of analysis looking at polypharmacy. Everybody says, elderly patients with heart failure and preserved ejection fraction, they're on so many different drugs. We can't add another drug. It's just going to result in more drug interactions, less adherence to treatment. It's a real problem in these older patients. And you can see here that some patients, very few, but some patients were on as many as 35 medications in the DELIVER trial. I mean, ridiculous number of different drugs. But if you look over here, again, you can see here the treatment effect was certainly not less in patients who were taking many different drugs. That probably fits with the frailty and comorbidity story. So to finish, I've talked about all the good things. I want to say something about safety because, of course, all drugs have benefits and can cause harm. And you probably know these data very well. So the things that cardiologists were worried about, ketoacidosis, very uncommon in our trials. In fact, it hasn't been a single patient without type 2 diabetes who experienced ketoacidosis in any of those large trials that I described to you. And also genital skin fungal infections, which are probably the most common specific side effect of SGLT2 inhibitors, even those are not that common. They seem to be a lot less common in patients with heart failure than in patients with type 2 diabetes. There are reasons for that. So half of our patients, or 2/3, don't have type 2 diabetes, and many of them have got chronic kidney disease. So SGLT2 inhibitors don't actually increase urinary glucose excretion very much if you're not a diabetic, and they don't increase urinary glucose excretion very much if your EGF is below 60. So most of our patients are probably not having a big rise in urinary glucose excretion, and therefore are not really at risk of getting genital skin fungal infections. But I want to come back to this early decline in EGFR, and you've all seen these figures. So there's this initial dip in EGFR when you start an SGLT2 inhibitor. It recovers. We don't really know why there is this recovery. This initial decline in EGFR tends to be bigger in people with a higher starting EGFR. It is smaller in people with a low EGFR. Very few patients, I mean, very, very few patients have a decline in EGFR to a level that might make you concerned. I chose below 20 mils here, but you could probably, you might not be worried about 20 mils, but very, very few people have a major decline in EGFR. And the important thing is that that decline in EGFR, that initial decrease in EGFR, is actually a marker of patients who are likely to benefit from the treatment. This is a very important message because it says don't stop treatment just because somebody's EGFR decreases. And this is looking at what happens to people after 14 days. And in the first 14 days, these are the patients who have a greater than 10% decline in EGFR between baseline and 14 days versus those who don't. If your EGFR declines during the first 14 days by more than 10%, you're significantly more likely to have worsening heart failure or to die from cardiovascular causes if you're treated with placebo. But if your EGFR declines by more than 10% in the first 14 days, you're less likely to suffer subsequent worsening heart failure or cardiovascular death if you're assigned to dapagliflozin. This just shows you it in a different way, taking more extreme reduction in EGFR. So these purple shows you patients who have a 25% or greater decline in EGFR during the first 14 days. If you're on placebo, those patients clearly do worse. But look at the dapagliflozin group. They don't do worse. In fact, they do significantly better. So those early decreases in EGFR are a marker of the drug having the action that you want it to have. Those early decreases in EGFR identify patients who are going to do better. And to finish with, I want to, I hope, put to bed one of the original safety concerns about SGLT2 inhibitors, which is that they might increase the risk of amputations. And in fact, these drugs used to have a black box warning about the risk of amputation. But in fact, we found that SGLT2 inhibitors do not increase the risk of amputation. So here are patients with peripheral artery disease. So they're a group who are at much higher risk of amputation. In fact, you can see here that they have about a 10-fold higher instance of the risk of amputation than patients without peripheral artery disease. But you can see that in the patients who got dapagliflozin, shown in blue, the risk of amputation is actually less than in the placebo group. But patients with peripheral artery disease are at high risk. So finally, just to mention, there are some ongoing trials. So there is still another acute heart failure trial. This is being run by the TIMI group in Boston. This is in hospitalized patients. It's a bit different than the soloist worsening heart failure trial, although I think most people are already doing this, so I imagine recruitment is difficult. And there are two really interesting trials, one of which we're going to hear about the results of later this year. And these two trials are in patients with acute myocardial infarction. So can you give these drugs to people at high risk of developing heart failure and prevent heart failure again, even in patients without diabetes? So watch out for these two trials. But this is my conclusion. So where are we in 2023 with these drugs? I've shown you 5 large trials, remarkably consistent benefits, early benefits, all the benefits that you could hope to get in your patients with heart failure. And the great thing is these treatments are very well tolerated and very safe. And really, we have, in a very short period of time, got more evidence in terms of the number of trials we have for these drugs than for any other treatment in patients with heart failure. And the last thing I would say about these drugs is that they're, I think, easier to use than any of the other treatments we have, which is great for our patients. So thank you very much.
So thank you, John, for this paramount summary of the results with SGLT2 inhibitors in heart failure and recent data with so clear clinical implication for the care of heart failure patients. So thank you very much. We have time for some questions, and the first is from the colleagues from Madrid, from the 12 de Octubre Hospital. And in the recent update of the heart failure guidelines was comment this recommendation of suggesting that should be indicated are the 4 pillars of heart failure before hospital discharge of the patient. And from Madrid, they say you strongly recommendation in the update. You can put class 1 indication or thing like this, or is it only a recommendation? And linked with this comment, how about the strategy? Because all of us know that 4 pillars for heart failure with ejection fraction, but this is saying almost nothing because you have to talk about a strategy. You are convinced that SGLT2 may be as a facilitator given early for improved optimization of heart failure patients, because using early this drug can facilitate or may facilitate the optimization of the treatment. How do you think about the recommendation in recent update, and how do you think about this possible role of SGLT2 inhibitors as a facilitator in this objective to optimize the earlier the better, the 4 pillars in heart failure with reduced ejection fraction?
So I think it is a strong recommendation because there is a trial called STRONG-HF that actually looked at people randomized to a strategy of rapid intensification of heart failure treatment. It was done before the SGLT2 inhibitor trials had really been published, but it showed that approach, even with our original therapies, our neurohumoral therapies, did reduce the risk of death and heart failure readmission. And then there was SGLT2 inhibitor, the empagliflozin and sotagliflozin acute heart failure studies, I think, all support the approach of starting these treatments in hospitals. So I don't think there's any question about that, especially as we know that in many places, if people go home from hospital not on treatment, treatment will not be started. You have a very good system here for your patients, but in lots of other countries, maybe even in other places in Spain, it's not the same. And if the patient isn't started in treatment in hospital, they may never be started in treatment after they go home. So hospital admission is a fantastic opportunity to do this. How do you do it? Well, it depends, because obviously many patients who come into hospital have established heart failure. They're on some of the therapies already. So the therapy that you might start will be the one that they're not yet receiving. So you might have a patient who comes in on a beta blocker and sacubitril valsartan, the mineralocorticoid receptor antagonist. Then obviously in that patient, you start an SGLT2 inhibitor. But if you take a completely newly presenting patients, then if you analyze the clinical trials, and we've done this very carefully, there's a very detailed paper in the European Heart Journal. The most effective strategy in terms of reducing events is to start with an MRA and an SGLT2 inhibitor. I would suggest in many people you can do that simultaneously. You're not going to reduce blood pressure. You're going to have very little effect on kidney function. And both of those treatments will help you decongest that patient who's been admitted to hospital. And then afterwards, the choice is whether you next add a beta blocker or next add sacubitril valsartan. I think if your patient's got a very low blood pressure, sacubitril valsartan is more challenging. If your patient's very congested, still got pulmonary edema, you probably don't start a beta blocker. So I think you have to individualize, personalize on the basis of some of your patient's characteristics. So for me, actually what I will often do is MRA, SGLT2 inhibitor, then a couple of days later, if the patient's blood pressure is all right in hospital, I will start sacubitril valsartan, and then before they go home, I will add a beta blocker, because I like patients to be as decongested as much as possible before I start a beta blocker, but you can reverse that if necessary.
So, any comments or questions from the Pilar?
Thank you very much for a lot of comments. My question is about cases with cancer. I have questions. Do you know if the trials is very data, and also if there is any ongoing trial prevention of diabetes?
So there are very few patients in those trials that I mentioned who have a history of cancer, and we've looked at that. There's too few to do an analysis. There are a couple of observational analyses, so non-randomized studies looking at people who've received cancer therapy who were on an SGLT2 inhibitor compared to patients who've received cancer therapy who were not on an SGLT2 inhibitor, so not randomized, observational, which is always tricky to interpret, but those data suggest that people on an SGLT2 inhibitor do better and less likely to develop heart failure. I know that there are several groups that are trying to set up trials using SGLT2 inhibitors, so prospective randomized trials, but I don't know if they've obtained funding, because I know there's been a problem in trying to get funding to do those studies, because all of these drugs are off patent this year or next year in almost all countries, and are already off patent in some countries. So the pharmaceutical companies are not investing any more money. So the problem is trying to get enough money and to get the drug and to get matching placebo, which is very difficult without the support of industry. So I don't know if anybody's been successful, but I know various groups have been trying to set those trials up. So at the moment, we've only got observational data. The observational data looks promising, but it isn't really enough, I think, to treat patients based on.
So, one final comment. Here in our department, we have several active groups of basic research with basic research with the SGLT2 inhibitors and another cardiovascular drugs. Regarding the mechanism of action, probably the benefit is multifactorial. this
Always.
drug. But if you have to recommend a new area for basic research with SGLT2, what would you recommend a basic research group? What do you recommend? Focus on energetics? So what do you recommend? A new or an area with possible expectation adding new results and new evidence on the mechanism of action, on the mechanism of benefit of the drugs.
Okay. So you're asking the wrong person. I'm a clinical trialist. But I think one of the things that's really intrigued me is that in GAP-HF, when we looked at reports of ventricular arrhythmias, ventricular tachycardia, and ventricular fibrillation, there was a significant reduction. And there is none of the trials are big enough to look at sudden death, but there is a very strong trend to reduction, specifically in sudden death. And I am intrigued as to whether or not these drugs have some sort of anti-arrhythmic effect. And that might also be interesting, not just for ventricular arrhythmias, but also for atrial arrhythmias. Because again, one of the diabetes trials that declared TIMI 58 trial suggests there is a reduction in atrial fibrillation. So I think looking at the effect of these agents on maybe isolated cardiomyocytes, looking at their electrical activity might be interesting. But I'm the wrong person.
This link with we are waiting for the final approval for publication. We review a real data of our patients, the real world data regarding the possible antiarrhythmic effects of SGLT2 inhibitors, and we saw in a non-randomized real world that the patients receiving SGLT2 inhibitors, the probability of suffering patients with devices also ventricular arrhythmias was significantly reduced under SGLT2 inhibitors. But I can say the journal was submitted for consideration, but it's the second review, and we expect that could be accepted. But I think this is linked with a possible proposal.
We didn't confer about that question.
No. I was probably with suggest, and the basic research here are taking this into consideration for planning a new project on the electrophysiological properties of cardiomyocytes under the treatment with SGLT2 inhibitors. So thank you very much for all of us. We will remember for a long time to stay with us. The yesterday lecture, this morning lecture, it really was a paramount lecture, and we'll remember for a long time to stay with us here in Santiago. Thank you very much.